So now I'm pleased to introduce today's luncheon speaker. Dr. Paul Farmer serves as the United Nations Deputy Special Envoy to Haiti in support of our last night's keynote speaker, who is the Special Envoy to Haiti, President Bill Clinton. Dr. Farmer is founding director of Partners in Health, a nonprofit organization dedicated to delivering health care to the poorest of the poor throughout the world. A medical anthropologist and a physician, Dr. Farmer is the Colocotrones University professor at Harvard University, chair of the Department of Global Health and Social Medicine at Harvard Medical School, and chief of the Division of Global Health Equity at Brigham and Women's Hospital. For many years, Dr. Farmer has addressed infectious diseases such as HIV, AIDS, malaria, tuberculosis, and cholera. But now his organization is becoming active in efforts to fight non-communicable diseases such as cancer and heart disease among the poor. Last month at the Clinton Global Initiative, Dr. Farmer and the leaders of the Lance Armstrong Foundation, AstraZeneca, Johnson & Johnson, the Mayo Clinic, and the American Cancer Society announced their commitment to action to fight non-communicable diseases. Please welcome one of the foremost leaders in global health and staunch advocates for health care for poor people around the world, Dr. Paul Farmer.
Thank you very much. I'm going to see if my entrance into clinic or hospital to do rounds couldn't be accompanied by music like that in the future. It's a real pleasure to be here. Any chance I had of coming in unnoted was sort of trashed last night by President Clinton, who not only told you that I was here, but also that this is my first trip to Las Vegas, which he found very amusing, I might add. It's the only place where I could follow a discussion with a series of pathologists with a dinner with President Clinton and then go see Elton John all in one night. And I'm sorry to leave, actually, and I thank you all for including me. I want to pick up on some of the points that have been made already, and certainly President Clinton made them last night. There is no, we have no chance of providing high-quality medical care without the lab in the world today. It's very difficult to find any example of doing a really good job without having appropriate support. I want to talk a little bit about our work and the challenges that we face, but I just want to start with this graph. First of all, something in me is just thrilled to be able to talk about profuse watery diarrhea while you're eating lunch. I never thought I'd be able to do that in front of 2,000 people. But, you know, my work is not that funny in some ways, so I do seek humor where I can find it. But imagine that you're, like my colleagues, in the middle of clinic. This is some data from Saint-Marc, Haiti. I was in Rwanda this day and got a call from my colleague, Louise Ivers, who has worked with me for 10 years in Haiti. She's an Irish but trained at Harvard, and she told me that in clinic that day there had been hundreds of people just showing up, including several deaths, and it seemed unlikely after what had happened, which is to say the earthquake a year before or 10 months before, that this was not cholera. It's a very distinctive clinical presentation, as you know. But the anxiety persists a year into this epidemic. The first case was a year ago, 2 or 3 days ago. But without laboratory confirmation, it wasn't entirely clear what to do. And some of that laboratory confirmation was bacteriologic. We also learned what drug susceptibility pattern this strain has. Even we're able to do molecular genomic typing of the organism and have a pretty good sense of what strain it was and where it came from. All of that is because we are linking or trying to link clinical services, what President Clinton called delivery, to laboratory confirmation. This is just an example that is really ongoing to this day. We are now still in the middle of this epidemic. In fact, in the 370 or so days that have elapsed since then, Haiti, which had never known cholera before, is now the site of the world's largest epidemic. And I'm going to return to that in closing, but I want to talk about some of the bright spots in our work and how the lab has helped us. This is a patient of mine and many other people, but someone I saw in Rwanda in 2005. I've had students at Harvard say, well, you've shown us this picture before, but in fact, everybody kind of looks alike when they're dying of a wasting disease. This man has two, not counting hunger, and I'm sure that you know what they are. In fact, we didn't need the laboratory perhaps to tell us that he had HIV disease, and which was true. But what we didn't know was that his CD4 count, without having flow cytometry, we would not have known what a CD4 count. Now, this man came into our clinic in rural Rwanda about a year after our arrival, so we put in a modicum of laboratory capacity already. So within a few hours, I knew that his serostat, I knew his serologies, and also the equivalent of staging malignancy, that is, what's his CD4 count. And it was high. By the way, of course, I'm using all of these images with the permission of patients. It was high, so we knew we had to look elsewhere and to understand why he was doing so poorly. His CD4 count was 600. And his chest x-ray wasn't that revealing, and we had to do a lot of lab work. He had profound anemia, and in the end make a clinical judgment, but based on lab data, and that was that he had disseminated or extrapulmonary tuberculosis. And so probably that day, I don't want to exaggerate, I'm not sure, but I think that day, could have been the next day, this patient, John is his name, began therapy with both antiretrovirals and also first-line antituberculous agents. And this is the same fellow just a few months later. Yeah. I'm very lucky in my line of work to see many, many cases like this, and it still gets me a little bit choked up when I look at pictures like this. And so then I tell a joke, and I've said to my students that he goes from looking like Skeletor to looking like he needs Lipitor. Now, why was I so confident in Rwanda in 2005 that he would do well? Well, because we've had a lot of experience. That was 2005. In 1995, as you'll see, for those of you who worked in teaching hospitals or in other hospitals, large community hospitals or hospitals in urban areas of the United States, you know that our hospitals were full of people really sick with destruction of their immune systems from HIV. But what happened in the next couple of years, I was at the time an infectious disease fellow, so I was training, subspecializing in infectious disease, again at Harvard, between the Brigham and other teaching hospitals there. And basically the hospitals cleared out because we use this suppressive therapy, like insulin for diabetes. This is not curative, but it is effective. And so mortality plummeted, and since that time, again, this is about 15 years ago, much of my energies, and a lot of President Clinton's, I must say, and we have a deep debt of gratitude to him, has been focused on making sure that the fruits of science and technology are available to those who need them most. And that included, of course, other people. When we talk about global health, we're not talking about international health. We're talking about global health as if Las Vegas were on the globe and Boston, but also Rwanda and Haiti. And so if we didn't do that, this is what was going to happen, and it already did happen. ART, antiretroviral therapy, definitive changes, significant changes in the United States, Europe, and those wealthier parts of Asia where it was readily available, and then this growing equity divide. And my colleague from Botswana, who you heard mention of last night, will know what this must have felt like in the field. That is, in her home country and many others, what we saw was this already bad situation becoming worse with a new pathogen. So by the time of 2000, HIV had surpassed tuberculosis as the leading infectious killer of young adults in the world, and was a very significant cause of pediatric mortality too. However, there needed to be more than just, we're not in the 19th century, we're in the end of the 20th, beginning of the 21st century. What was our equity plan? And of course, this is my message to the Ascp. What is our equity plan going to be? Are we going to really act as if we're a global society and understand what it means to not have an equity plan? We do understand there are significant health disparities in this country and in the world. But the good news is these are all disparities that could be addressed. Now, this is some of the logic that we faced, and I think we always face. And certainly, I'm going to show you examples from commentary about cancer in poor countries. And I've took the names off these pronouncements because I don't really think, it's not my intention to critique individuals who made these statements. They're high-ranking U.S. officials. The point I'd like to make is a failure of imagination is a central, or maybe even the central problem in modern medicine today. And by medicine, I mean public health, laboratory medicine, nursing. That is, those who would link sound knowledge that comes often from a lab, because it really does, to delivery systems. Our biggest problem is really failure of imagination. The biggest problem we've had in Haiti over the last year, getting the vaccine deployed, was a failure of imagination. And we're still finding that. And there's a lot of articles in the newspapers today. Again, I couldn't believe that President Clinton had already read them when they appeared yesterday. He was already quoting them last night. This failure of imagination has been crippling, and we really need you and the professional societies to help us address them, as you are doing. Now, when you make claims about the cost effectiveness of certain regimens, if they're life-saving regimens, treatments, or diagnostics, you've got to be very careful that you're not making errors about either cost or effectiveness. And remember that we're in the same political economy. That's why there's a cholera epidemic in Haiti. It's because it's rooted in the political economy. This is another patient of mine who actually is the daughter of a friend of mine who was dying in the summer of 1999. A year later on antiretroviral therapy, she's taking care of her own children. So again, imagine what a colossal error we're making if we don't understand cost. Like, what is the cost of inaction? For her family, it would be the orphaning of her children. And then because she had a good system, a delivery system, and labs are all about systems. You've all said that. President Clinton said it's absolutely true. The system that we use not only involves a lab, but the delivery system involves community health workers. And we call them accompagnateurs, those who accompany. With good accompaniment, she's still on the same first-line regimen 10 later. So you have her dying in 1999, a year later, and then giving a lecture at, of all places, Harvard University 10 years later. Still on the same first-line regimen. Now, one day, there's little doubt she will need second or third-line drugs, right? And that's where the lab's going to come in again. We'll be able to follow her CD4 count, viral load, and eventually probably do a genomic test to see what mutation she has, and then plan out her regimen. She certainly is due for such a change. We can't do that without the lab. And to have a failure of imagination to say that this test cost $1,000 and therefore is not relevant to resource-poor settings is a great failure of imagination. Let me give you some proof. Remember the claims that I showed you from leading U.S. officials about how much a regimen costs, $10,000 per patient per year. You heard President Clinton talk about the all-over-the-map prices that he saw when we met, actually, he and I in Barcelona to talk about this at the AIDS meetings. This is not a projection from some modeling exercise. These are real data. The average wholesale price for a 3-drug regimen, here's 2, doesn't matter which they are, in the United States, $10,000 per patient per year. What Partners in Health was paying at that time, usually under $700 per patient a year, and then prices negotiated for others, including us, by the International Dispensary Association. Again, same regimens, $300 a year. And then that's when President Clinton got involved with the help of he's always giving credit where credit's due to the Clinton, then called the Clinton HIV/AIDS Initiative, now called the Clinton Health Access Initiative. They got involved, helped us to negotiate those prices down without a loss to the manufacturers, mind you, to $60 or $70 per patient a year. I'm only showing these numbers because it's catastrophic to believe that the numbers are set in stone as if God handed them down like the statues in front of Caesar's palace that I saw last night. You know. So be careful. We always have to, you don't have to be careful, but people have to be careful talking about cost or effectiveness. Now, effectiveness. If there were alternative treatment strategies for AIDS, I'd like to hear about them. If there's alternative treatments for acute, leukemia in children, let's hear about them. But when we have a standard of care, part of the goal of an equity plan is to make sure and learn how to roll that out where it's needed most. Now, that's just what happened with AIDS. This platform that you heard about has now been built. In Botswana probably has a great majority of its those needing HIV treatment on therapy. In Rwanda, and I'm going to show you this, I'm just going to tell you that it's been one of the most stunning things I've ever seen in my life as a physician, to see the Rwandans go from under 500 patients on therapy, on good supervised correct therapy in 2004, to near universal access with 90,000 people on therapy. Now, that's an astounding achievement. It's also a platform for other chronic diseases, non-communicable diseases, including, as was mentioned, certain cancers. This is what we've done with some partners. Always the Ministry of Health, Partners in Health, which is a partnership organization after all, the Clinton Foundation. And we've already done what I'm going to talk to you about in great swaths of Rwanda, parts of Malawi and rural reaches of Lesotho, and a little bit of Burundi too. This is an example. And I would also invite you to think about how to start conversations rather than end them. It is true that we cannot afford to have multiple vertical programs. And President Clinton talked about that last night. Doreen has had the same experience in Botswana, where you're shuttling patients around from place to place for service to service. It's very common in the United States as well. That's not the way we designed this project that I'm going to show you. We went into an abandoned hospital. That's the above picture. And PHC, as you know, means primary health care. It was always our intention to deliver primary care, that is, for whatever people came in with. You can have a national AIDS program, but when someone comes in with a fractured humerus, you can't say, you need to go down to the fractured humerus program down the road. I'm glad some people like my humor. There's not a national, epilepsy program or a national, there may be a national cancer program, but their penetration into rural areas of Africa is nil. So we always need to rebuild a hospital and link it to clinics, etc. And that's just what we did. And it's been very gratifying work. This, for example, is a before and after picture of a hospital in northern Rwanda that had no doctors in 2004, not one, maybe 300,000, 400,000 people. And this is where I was trying to get Phil Castle and others to go and visit, and will, I'm sure. This is now a beautiful modern medical center that was built on the site of a military base. So, as far as swords into plowshares go, that's pretty exciting. I met with the board yesterday and said that even the most mediocre hotel in Las Vegas is still better than some of the best hospitals in all of Africa. That's a shame, and we can change that. If you can plate lunch for 2,000 people in 10 minutes, imagine to say we couldn't possibly roll out, say, cervical cancer diagnosis of care. It's just not true. This slide I'll leave with you. We put it into our review in The Lancet last year. The majority of incident cases of malignancies in the world today are in low and middle income countries. And we have the same kind of discouraging comments from some saying, well, it's really not cost effective in resource poor settings. And I just invite you to again, politely reject that counsel. This is, again, before and after. KS, this is a patient from rural Malawi. KS, as you all know, is it actually does require a laboratory diagnosis. There are, you can get pretty good at diagnosing KS, but there are other ailments that look a lot like it. But the thing that I'm thinking about here is not so much the diagnosis as the delivery of services. This is after just one cycle of paclitaxel, and you can imagine what that's like for the patient. Now remember the claims that it's not cost effective to treat cancer in poor settings, and the slide that I showed you about the all over the map price disparities. Does this look familiar? It should, because it shows you the same almost crazy disparities of prices that we've seen. And I put this picture of Lance Armstrong and President Clinton here because I think they and others who have survived cancer have helped in many ways more than some of the experts, because too soon we're ready to declare defeat when we're talking about the well-being of people living in poverty, and that's just not acceptable. We have tried to integrate cancer prevention and care into rural hospitals. That requires, again, integration, as we were discussing with Doreen and others earlier. It requires pathology, which is not available necessarily yet, and significant collaborations. I'm going to tell you a little bit about some of ours. This is a collaboration that we've tried to launch. We have launched with the Brigham, and I'd like to thank Jim Papoon, who's here today and a member of Ascp, the Dana-Farber, which is the preeminent cancer institute at Harvard, again, Partners in Health, and the Ministry of Health in Rwanda. And again, the ASCP is already working with us to strengthen this rather modest collaboration. And this requires, again, that supply chain, laboratory capacity, the ability to diagnose, to track results, and then to deliver care. That's what we really need to focus on, and that can't be done without partnerships. It can't be done without laboratories. It also can't be done without community health workers, nurses, physicians, and public health officials. And I think this is just one of the places in which we can really be the first over the line in one of the poorer countries, significantly poorer than Botswana. But Botswana is obviously another place where, as President Clinton noted, there has been significant investment in healthcare and the social sector in general, and there's also stability. And Rwanda is just such a place, if behind in some other areas. And of course, we see results like this in Rwanda as we would anywhere we would work. Now, one of the conversation stoppers that I've heard a lot, just as with AIDS in 10 years ago or 15 years ago, you can't treat AIDS in Africa because you don't have any infectious disease doctors. And I kind of joke around and said, you know, I've never heard that from a patient or a family member, only from my fellow infectious disease doctors. You know, if the beginning and end of the conversation is, well, we can't treat cancer in Africa because there's no oncologists, well, you know, that's a great way to stall things. But there's plenty of cancer in Africa, as I've already shown you. So again, sometimes we need to think outside the box and train, of course, oncologists, oncology nurse, and build up the laboratory capacity. That's just where we are now, I think, with the society. And we see, again and again, these are some kids from Rwanda, and you know, it's not true that you can't deliver chemo. I'm not saying that it's easy. I'm just saying that it's a lot harder to die on a tentative cancer than it is to deliver chemotherapy without oncologists. And you know, these startling results are seen all over the world where we actually fight to remediate disparities of access to diagnosis and care. This is another one of my favorite handy little drugs, which is a chemo regimen that, of course, is a PO drug. And there have been a lot of partners in this making Gleevec available. Foundations, the Max Foundation, for example, and the manufacturers, and, of course, the patients and their family members. But you need the laboratory diagnosis. And it's not a diagnosis that we can make yet in Rwanda or Haiti or many of the other places where we work. We have to send chromosome we have to do the testing here in the United States. One day, though, we'll build the capacity to do more of this testing and very high-quality lab work elsewhere in the world. We're building it now. So to summarize, the big problems for us are tardy diagnosis, again, not enough lab. There's a lot of ineffective therapy, which eats up enormous amounts of money for poor people. Most people go out fighting, as you know. Their family members look out for them. They end up spending huge amounts of money, yes, on traditional healers, but also on people with MDs after their name who don't have the tools of the trade. So people can fritter away all their life's savings and every bit of livestock, housing, everything in order to save their children and family members. And in the end, they don't get the right therapy because they don't have the right diagnosis, or we don't have the deliverable, the chemo. There's a lot of loss to follow up. Again, not an insuperable problem. All you need are community health workers to work with you. And to have them work with you, they need to be stipended, trained and stipended or paid. And then there are all these hidden costs that no one's studying yet. Or actually, there are now people studying them, and I think it's very exciting to bring in a whole new generation of economists and others trained in social sciences relevant to medicine who actually go and look at how much it costs to not act. There's also the challenge, you heard a little bit about this last night, between the discussion between Blair and President Clinton. We really have to integrate prevention and care. Cervical cancer offers the best chance we've got to see a ranking killer of poor women almost disappear in our lifetimes. We have the vaccine, we have early diagnosis. This is just a picture of a colposcopy session in northern Rwanda, in that same village that I showed you, and the doctor teaching other doctors and nurses how to do this is a Malawian colleague. And we have lots of Haitian colleagues who have been in Rwanda, Malawi, Lesotho, Burundi. So this movement for global health equity involves not just the people who might come to the wild and wacky Las Vegas, but people all over the world. And we have many, many partners. And the society will have many partners once now that you've plunged into this exciting but often difficult work. There's a way to make a list of some, just looking at cancer. I could have talked the whole hour about cholera. But we are able, this was through an exercise with Larry Schulman and others from the Dana-Farber Institute and other colleagues, Felicia Knoll, who heads up the Global Task Force for cancer care, coordinated cancer care. You know, we can find which malignancies are most likely to respond to aggressive therapy, meaning aggressive acting early, and which regimens we need. And then we can think about systems as you do in the lab. How can we have pooled procurement and sensible distribution of these agents, diagnostics and agents, and vaccines based on burden of disease and need rather than based on ability to pay. You know, letting uncreative financing mechanisms stop us is not an acceptable answer either. It's not that you are called to figure all this out, or I, a clinician, am. That's not what I'm saying here. I'm saying we can work this out collectively in partnership, working with economists and leaders of nations and international organizations. Look what President Clinton helped us do around HIV diagnostics and therapeutics. And that's just a handful of people. I mean, that's a pretty small charitable organization, with very small group of very committed people who know what they're doing around procurement and around working with manufacturers to lower prices. We can do this with diagnostics, with lab deliverables, and I know with the society on board, it'll just move much more quickly. You've already got your working group in Africa. I couldn't pull together all the pictures from the web. Larry Schulman is my friend and colleague, former teacher. He's over. I never can tell whether that's the right or left corner, but I know it's where the left lung base would be on a chess film. That's Larry. Phil would, of course, be in the left apex of the lung. Anyway, we need you as our colleagues. We're very excited. We're a little bit overwhelmed. We don't have all the answers. We're pretty humble about what we don't do well. I can't tell you how grateful I am to people like Jim Papoon and others in the Brigham lab who are so patient with us as we botch specimens because we're putting them in formalin or the wrong things. It takes us a while to get better. sort of like in the operating room, the anesthesiologists and the surgeons. You know, the anesthesiologists say, oh, we're on the right side of the blood-brain barrier. Us clinicians are not as fast as you lab guys and gals. So be patient with us, work with us, accompany us. That was my take-home message to the leadership of the society, is we need you to accompany us over the long term. We've been doing this for many years. It's a life's work for us. Many of us are lucky to do it full-time, as I almost do. I am a professor and administrator at Harvard, though. It's not really full-time for me. Even if you have a little bit of time, it's what matters to us is the duration of engagement rather than the amount of time you might have every week or month. With long-term accompaniment, we can really solve a lot of these problems before us today. Thank you, and I look forward to our discussion. Thank you very much.
So our mics are on? Excellent.
Love you back. I feel like I'm the President Clinton of the global health equity movement here.
So, Dr. Farmer, all these people out there, they love the science and practice of pathology and laboratory medicine. That's why they're here. And I know they all want to thank you for being their colleague and their friend at this meeting. So once again, thank you for this tremendous opportunity to be with you. We have some questions. We will start out with a question or two from this end of the stage, but then we're going to open it up to the audience and have these people who love pathology and laboratory medicine ask you a few of their own questions. So I'll start out. We talked a lot about systems. President Clinton talked a lot about systems, and you mentioned very rightly that lab people are systems people. So given the shift in emphasis in global health from disease-specific approaches to focusing on health systems and infrastructure, how do you see labs, and in particular societies like Ascp, participating in infrastructure building? What needs to be done first to start this ball rolling?
Well, first of all, the good news is I don't think that we need anything from the members of the society that they don't do or have. That is, what we need you to do is help us build up lab capacity. Of course, there will be people here who can help us in other ways. I mean, I could go back to the earthquake in Haiti and the outpouring of support that we had from people all over this country and indeed all over the world. That's just an example of reaching beyond your own professional training because you care about people who are suffering or in trouble. But from the society itself, I think what we need is lab help. And to be very much specific, and I'm going to go into a little bit of jargon. I hope you'll forgive me. So in public health jargon, an AIDS program is a vertical program, right? A cervical cancer program is a vertical program. And as President Clinton hinted, it can get even more splintered. It can be an HIV prevention program, a mother-to-child transmission program, a treatment program. That's not a good model. It might be a good model to get things going. I went to rural Africa many times before we settled down to work there. And I'd see in the middle of nowhere a clinic that said VCT, voluntary counseling and testing. So there's a VCT clinic, but no treatment. No wonder they were empty, right? Why would you? And as soon as you could integrate the testing and prevention with proper care, they filled up. And when you remove the barriers, which are usually users' fees, they really fill up. So the model that we need is an integrated platform, to use Silicon Valley jargon that has now infected all of us. We need platforms, and they should be primary healthcare platforms, as I said earlier. And then division of labor is not driving patients from pillar to post to have different services in different places, but have the expertise of a group here help us build up laboratories. And again, I think a 10-year commitment is a minimum, or 20, because first of all, let me just give an example that won't occur to a lot of members of the society. And I joke around with my surgical colleagues. You know, they're lucky, I say, when they're working in the Brigham, when they can do a biopsy, they don't have to actually build the operating room and put in the electrical supply. We do. I didn't go to Harvard Medical School and train in infectious disease to learn how to build, you know, generators. Yeah. It's just that we didn't have enough help back then. Now that we have more help and have built these platforms, we'd like you to help us improve standards, put in place laboratory, improve standards, and then build local capacity. And I know that ASCP knows this. That means going from 0 pathologists or medical technologists to the hundreds and thousands of medical technologists and lab. You know, the histopathology example is a great one. We need lab techs, we need labs, now we've actually just built in northern Rwanda, as you know, a very lovely facility. The histopath lab we're going to ask our friends like Jim and others to do that for us. I don't think it's a good job to have me trying to figure out how to do a histopathology lab when we have, you know, 2,000 people in a room like this one listening. So I don't know is Jim here in this room? Yes, no. When you see him, tell him thanks loads for coming to my talk. But you know, we need to actually have people with that knowledge to receive also the interest. So laboratory work, training, local capacity building.
ASCP is all about that. It's about workforce capacity building. We certainly know the technology that we use and exporting that technology, making sure that it's in place, including all the supply chain activities that are around that is obviously critical integrated system. So, are you concerned that the shift towards addressing non-communicable disease in the developing world will have a negative impact on the treatment of people with infectious disease? So you're worried about shifting resources here? No,
I'm not really worried about shifting resources because we've always been about the burden of disease. I went into infectious disease because that's what I saw in Haiti 28 years ago. And I told the story. I was at Stanford this weekend with a bunch of students who, by the way, these are students, undergraduates. They founded an organization, this should warm your hearts, called Face AIDS, and in the last few years, these 20-year-olds have raised $2.3 million for Partners in Health. So, which again, if they can do that, then we can certainly do our jobs. But they asked me the same question, and it's not that, you know, as I said to them, gathered at a Face AIDS conference, after we face AIDS, we'll face cancer, we'll face hypertension, we'll face rheumatic heart disease, we'll face whatever it is that ails people. Major mental illness is very neglected. So I'm not concerned that putting another part of the burden of disease in the limelight is going to take resources and interest away from infectious disease as long as we build systems. Because if we build good systems, platforms, with good delivery mechanisms, procurement mechanisms, reaching out to people where they live, then that should serve everyone, whether you, again, have a fractured limb or, or diabetes. So the problem is this constrained thinking I thought President Clinton did a very lovely job last night, but one of the points that he tried to really push home was there's too much conflict when really competition is called for. That was in many ways the most moving part about what he said. So it is in public health. And instead of having competitions between microbes and non-communicable disease, only the pathologies are going to applaud our division on that. They're probably happy. The mosquitoes are going, yeah. Plasmodium are saying, let them argue amongst themselves. I sometimes do have these images in my mind when I see, histopath arguing with, microbe.
We never argue. Never, ever, ever.
Yes, I know how polite professional society can be.
Yeah, ASCP clearly understands that a test doesn't predispose whether it's infectious disease or a neoplastic disease up front. It's all about the system that figures that out for you.
And if you actually look at a lot of the non-communicable diseases, they are communicable diseases.
Yes, they are.
I mean, cervical cancer is a viral disease.
Cervical cancer, yeah.
Rheumatic heart disease. If someone says, that one day there's some infectious pathogen involved in diabetes, some of us won't be surprised.
Yeah,
but
absolutely.
the real point is, where's the burden of disease? How can the fruits of science and technology be brought to bear on this tsunami of suffering that's really avertible?
So the next question is...
That was a very mixed metaphor.
The next question is about where you've done great work in Rwanda and Haiti. You've done such great work there, but aside from financial resources, what do you need? What's the biggest barrier to you sort of taking the next step?
Well, I could say resources still, because these are very under-resourced illnesses. By the way, a friend of mine edits a journal called Public Library of Science, NTDs, Neglected Tropical Diseases. And I always joke with him. Some of you know Peter Hotez. And I say, Peter, all diseases of poor people are by definition neglected. Yeah. And one of the things that's lacking is resources, as you said already. But beyond that, I was talking yesterday with some people on a conference press call. I haven't done many of those in my lifetime, meaning press calls, but 27 journalists were on the line. I was in Los Angeles. Louise Ivers was in Dublin, and we're talking. She's Irish. We're out looking for resources for a cholera vaccine. Some were calling it trial, and I said, it's not a trial. It's already gone through trials. It's a rollout for poor people. Stop calling it a trial. Some of the journalists actually picked up on that. But so we do spend way too much time looking for resources. Beyond that, what I said then, I would say again today, one of the biggest problems is sort of professional ADD. After the earthquake, we had so much interest in Haiti, and now the great majority of the humanitarian groups that were there are gone, but there's still all these homeless people. I'm sitting at a table with someone from Louisiana who's a founding faculty at Tulane. You know that the problems caused or exacerbated by Katrina are not dealt with yet, on the housing stock in New Orleans, et cetera. So that's a big problem, ADD among our partners and ourselves, right? So that's why we're trying to, my colleague, Dr. Jenny Block, who's with me today, is not a pathologist or a doctor. She's a theologian. It's actually, President Clinton knows her very well. She used to be a nun, and I saw her at the blackjack table, and I thought...
Well, they have a lot of time to practice.
But, sorry, Jenny.
Wherever you are. How'd you do?
The blackjack, the former nun at the blackjack table. Anyway, one of the things that I've learned from theologians and others is that this is very much work of accompaniment. So what's the opposite of this short-term attention? I don't know how long the tenure of a society president is. I know it's very brief.
Mine's only about 24 hours.
Yeah, yours is almost over. But I know that, but that doesn't mean you're dropping out of the society. I mean, you're a lifetime, engaged with your profession over a lifetime. This is not a hobby, what we're doing. We've got to take it seriously, global health equity. So the biggest problem, I would say, is we need long-term patient accompaniment. And with that, well, let me put it this way. We know that the problems are enormous, so there's no lack of need. Our ability to understand them, and as President Clinton said, describe the problems, is really quite sound. We have most of the tools we need to make a huge difference. So the big challenge is delivery, implementation, and that requires a lot of really patient accompaniment. And when you're working in, with a Ministry of Health somewhere, maybe it'll take more time, more patience, but the end result will be more sustainable because you'll have invested heavily in local capacity building.
It's all about presence and walking the walk.
Well, Jenny actually, and I interrupted you, but Jenny calls that the ministry of showing up.
Absolutely. Absolutely, I agree. So I saw on one of your pictures the mug of a colleague of mine from the University of Pennsylvania, Dr. Tim Rebick, and he's a clinical epidemiologist, and he is president this year of a group called Aortic, which is a cancer research organization in Africa. Certainly Phil Castle, epidemiologist in cancer. And these people tell me that they're not sure about their data in the continent because they don't have pathology. So could you comment on other aspects of developing structure in pathology and laboratory medicine beyond just the delivery of healthcare? How do you know what you know in the continent?
Well, I think you don't know. I think that's a quite correct critique, that it turns out that a lot of the data that we have from global bodies like the World Health Organization is largely the work of extrapolators. And so burden of disease assessments, and some of my close friends, including Chris Murray, who I trained with, he's now at University of Washington, he explained to me when I look at these magisterial numbers, right? They look so official, you know, global cancer database. And you know, when you explore them, they're really almost all extrapolations. Same with HIV back 15 years ago. You know, you take data from a clinical setting, a prenatal clinic, and then try to extrapolate it. Very few places in the world even have the capacity to do pathology data banks, right, to say nothing of population-based surveys. Now, one of the problems, I think, is that the public health community takes this as another conversation stopper, right? We don't have the data, we can't do anything. There's got to be a clinical term. It's probably in the Diagnostic and Statistical Manual of Mental Disorders, edition 5, where people become paralyzed by a lack of data. That was pretty funny, I thought, but medical humor didn't work here. But I think we have to. It's a tension on the words. No data doesn't mean no action.
Right.
You know, it means find ways of confirming diagnosis and build data over time. So I think, you know, Tim he's an epidemiologist, so he's going to be looking for population-based data. So are we, but that didn't mean we couldn't start with our therapeutics and lab work, which is what we did. So that would be my recommendation to society. You know, point out the weak reporting capacity, the lack of sound data. You don't know what's happening, and that's critical to get a sense of burden of disease. At the same time, one of the best ways to get information, and certainly the best way to make yourself valued in a place like Botswana. We had a candid conversation with Doreen earlier.
Yes.
You know, people coming in and doing even research on burden of disease without any therapeutic plan is not very welcome in much of the world.
Right.
I wouldn't welcome it in Massachusetts, and they sure aren't going to welcome it in Haiti, and I don't see why you'd welcome it in Rwanda or Malawi or Botswana. So we have to really span that line. Clinical labs are the best place to do this, of course, right? I mean, you're the ones who give clinically useful data that is also very often the stuff that will lead to the broader population-based surveys.
Dr. Rebick, Penn let him off the reservation for a few months of sabbatical, and he was running around the world talking about aortic and this problem of the surety of data because of lack of pathology. And the email trails that developed from all his conversations turned into this tremendous hue and cry for better infrastructure, for better data so that we can provide better therapeutics. And it's a great, great story.
It's a great story. It is the story of linking all of the parts of the equation that we can finally do to deliver services. To, you know, if you think about it from, you know, the preventives, the diagnostics, the therapeutics, you know, I'd mentioned HPV vaccine, which evidently causes terrible autism or something like that. I missed that whole thing. Anyway, you have an HPV vaccine, you know, and which, you know, can prevent the great majority of cases.
Yeah. You
You have early detection, and you have all sorts of therapeutic things you can do all the way along the way. I mean, we still do XRT for palliation, and then everybody jumps on us for not doing sustainable, cost-effective medicine. Just, again, it's not the right way to see it only from a population-based perspective, but imagine linking that powerful, it's really power of science and lab work each time, whether you look at the vaccine or the diagnostics or the therapeutics, it comes from you guys. Link that to a public health system that can deliver, and you've got very exciting developments.
So I'm going to invite the audience to offer up a few questions for Dr. Farmer. We have 4 mics out there. There are staff at the mics who will help you there. And I see a question over here on our left side, Dr. Farmer. We'll just orient you. We are anatomic pathologists too.
That's the right lung apex, or maybe right middle lobe.
Hi, my name is Sean Tucker, founder of Laboratories Without Borders International, and I've been working with Heart to Heart International in Haiti. We just got back in August. I'm sorry, can you hear me?
Now I can.
All right, very good. We just returned from Haiti in August, where we set up 2 new laboratories, and we're trying to start Pap smears over there, and we were wondering if you actually send your slides over to the United States for observation or use telemedicine. And then I have a second part question, if that's okay. They're also very interested in starting HIV testing at these 2 clinics. However, we don't have support networks to do the counseling afterwards. Yeah. And I was wondering if you had any observation about partnerships in order to be able to take care of that situation.
And this is in Port-au-Prince or no?
This is one in Port-au-Prince, and the other one is over in Léogâne.
Yeah. Well, actually, a friend of mine who worked in Léogâne is here today. I'll introduce her to you. She's a pathologist, Dr. McNeely. He's at the table right in front of you. But let me just say that we have, again, humility is warranted here. We've tried a lot of things with Pap smears. We tried sending them to the States. We've worked with people at Harvard, at Columbia. It's a cumbersome procedure, as you know. It delays our ability to follow up with patients. It's been a hard experience. So we've also focused a lot on colposcopy with acetic acid and early treatment. All of that we're doing in sites in rural Haiti. We have a director of women's health. I'll be glad to connect you with him. He's actually taking a well-earned sabbatical himself. Dr. Maxime Monville. He's still back and forth to Haiti from doing an MPH in Miami. So we did send them back. It works a lot better when you can do one-stop shopping, diagnose a lesion, and treat it. Now, the equity arguments are really critical. We do have to figure out what is the highest standard of care and promote that. And I've been reading, as you have, in the popular press, New York Times, about arguments around using acetic acid. We started this, by the way, we got a colposcope when I was still in medical school from Louis Burke at the Beth Israel Hospital in Boston, that 20-something years ago. And so it's been a long journey for us. I think we'll have a lot more forward movement working with people like Blair and people in the society who can help us, not just with protocols, you can pull those off the internet, but really, again, this long-term accompaniment. And you'll need that too in Haiti. Classic example is the second part of your question. There's no reason not to do HIV testing in Léogâne and in Port-au-Prince. There are a number of organizations there. The largest organization is in is in Port-au-Prince, Geskio, which does free voluntary counseling and testing, pre- and post-test counseling, and is connected to lots of different organizations, not just in Port-au-Prince, but across the country. Not easy for the patients, of course, to get from one part of Port-au-Prince to another, but it's still, something that can be, that you should connect with those people, and I'll tell you about the contact info. Same in Léogâne. There's a lot of NGOs. They're not very coordinated. I'm sure you already saw that. And it's great that Laboratories Without Borders would be partnering with other NGOs. You just need to keep on building the partnerships. Not easy to do, easier to say, but possible. And we'll give you some of the specifics, myself or Jenny.
Thank you very much.
Thank you.
I think we have a question on the right-hand side.
Hello, I'm Dr. Marcia Kilsby. I'm from Andrews University in Michigan. I don't know if you know that an ASCP 2010 Medical Laboratory Science graduate is in Haiti at the Haiti Adventist Hospital. What we found there is for the year after the earthquake, 1,000 volunteers went through as helping, and not a single person from the lab. And the physicians were telling me when the infected orthopedic injuries that they were smelling them to tell what the organism was because they couldn't do any micro. So this young lady, Brittany Blair, went down volunteering for 1 year without pay to upgrade the laboratory. In 5 months, she was actually giving lectures in Creole to try to help the infrastructure and the quality of lab delivery. What would happen if we had more of these young people that were there long term, that could help build up the capacity, the education of the laboratorians there in Haiti? Would that help? One of the things that we've found also is these young people are stifled by the fact that they usually have student loans. What if ASCP had some kind of a Peace Corps kind of program where they could be sponsored long-term, resident pathologists, laboratory scientists, to really help make a difference long-term in building up the infrastructure?
Thank you very much. First of all, God bless Blair. Did you say her name is? No.
Brittany Blair.
Brittany Blair. Blair's everywhere around here. So, I mean, you've laid it out. The challenge is, again, the long-term part. And once you there's a lot of volition, I think, especially in younger people, lab techs, pathology residents, everybody. Structuring that and financing it is a big challenge, and it shouldn't be on her shoulders, or even I could add mine, right? I spent a lot of my time, as I said, looking for resources, including for training health professionals in Rwanda, Haiti, at Harvard. And it's until we have a robust, and I would even argue federal support is a good idea. You heard about PEPFAR last night and a little bit today. Those are huge outlays of American taxpayer dollars. They need to be accompanied by training efforts and stipending. It can't just be Americans. It's got to be Americans and our partners in Haiti. The one thing I would caution, which you've already clearly understood, is that without a connection to delivery of services for patients, there's what some of my Haitian friends call a folkloric cycle, where there's lots of trainings and trainings of trainers, but never really reaches the people who need it most. That's got to be, we have to be a little bit stricter about that than we have been. Because, you can spend even a year in a lab where people don't have access to the lab because of all the user fees. It's this really tough problem. The society has 120,000 members. It seems to me that would be a great idea to start a small number of, of programs. I mean, we're working we've been talking with the society about Rwanda, I know Botswana. There's 17 countries in Africa. Obviously, I have a great deal of interest in Haiti, and was talking with Ray Aller at USC yesterday. He's here today. What we need is this long-term commitment, as you said, but also what's the link to delivery, and more rigorously, what's the link to delivery for poor people? Because in my experience in Haiti, the biggest barrier is always the user fee. It's always how much it costs for the lab test. And, someone like this young woman you described could in the end become discouraged because she understands, as I did early on, that without an equity plan, you're not serving the poorest. After the earthquake, a lot of those user fees were suspended, but there was a great deal of hollering from providers to reintroduce them, and most of them have been reintroduced. They're the bane of poor people needing laboratory diagnosis. So it's a tough structural problem, systems problem, but with the right analysis on the ground, that is, how can we make sure and link the lab testing and training work to delivery, then avoid that folkloric training cycle, and then how can we help young people either have debt forgiven or help them to pay off some of the debt through professional societies. I think that's the way we should move forward. So thank her for me when you talk to her again.
I will be happy to do that. Thank you.
Thank you. I think we have time for about 2 more questions. I think we have one in the back, which was first, and on the left, and then one on
There's
the front.
the right apex showing up.
Okay. So in the back on the left.
That's
yes.
a Pankos tumor if I ever saw one.
Oh my God, Dr. Pankos.
And that was a sophisticated pathologic joke. No laughter. I'm the one who got President Clinton to say tumor is rumor.
Is that Melissa back there?
Yes, thank you very much. I was very moved by your comment about philanthropic ADD, because I think one of the elements of evil and of problems in the world as we become overwhelmed by the magnitude of the problem. And it seems as if the road out of solving problems, the road to solving problems, is where two or three are gathered together. It's the relationships between people that can be forged. I'm very excited about the possibility of a long-term relationship forged between ASCP and the work of Partners in Health, but I'm also interested in your comments about how we can forge effective long-term relationships that focus on problems that can be resolved with that kind of relationship building and network of support, where we can learn from each other.
Well, it's an almost philosophical question. I mean, I agree with what you said. I feel overwhelmed. I hope can't tell that. And I hope my patients don't know, or my students, but it's very overwhelming. The enormity of the problems, even as you said, the inrush of goodwill without a strategy to translate that goodwill into really an outcome, that we need, and that have systems, real systems in place. And I think you're right that it does, that we can use partnership and really fellowship is what you're describing to spark conversations, to get things going. And indeed, a lot of what I've been lucky enough to see has come out of friendships. I'm very good friends with the Minister of Health in Rwanda, who a number of you met when the Ascp went to Rwanda. But that's not how I became friends with her. We've been friends for a decade. And she then became the head of the National AIDS Program, and then the permanent Secretary of Health, and only has been the Minister of Health for the last year or so. And that's 10 years of building up a working relationship that is based on, trust and admiration and friendship. So, but if it only were stuck, if the work that we're doing, with the Clinton Foundation were, dependent on my friendship with President Clinton, that wouldn't be good either, right? We do have to have systems to move this forward. So just like in the labs, it's not based on personal relationship. It may come out of that, and that has been always, I'm sure, when we see human progress, which we see a lot of, I think, it may have roots in that fellowship, but then building in systems is something that I think only honors the fellowship more. I don't know if I answered your question. I'm really mostly agreeing with you and saying, and then how do we move on from that? Because I'm leaving. I'm leaving for Notre Dame this afternoon. But whether I'm here or not, I'm hoping that the society, it will, as you said, work with Partners in Health and our other partners. I mentioned several of them, the Ministries of Health, the Brigham, Dana-Farber, et cetera. I'm hoping that this will become systematized, just like we would demand with quality control in a lab. Thank you very much.
In a computer geek sort of way, it's about building the interface engine between partners and ASCP.
Yeah.
We'll take one more question.
Hi, Ray Allard from USC.
Hey, Ray.
Thank you for your comments today.
How'd I do?
You did great. Totally.
He's a tough critic.
Well, totally
He's
different
great.
talk than a couple days ago, but both great. Thank you.
Now, why would you want me to repeat my talk to the ASCP that I gave to undergraduates at USC?
I've heard it done elsewhere. But no, the question I had is, we've been talking about the really daunting challenges that we have to build personnel, supplies, et cetera, to build laboratory capacity. But what we're looking to do is increase the quality of laboratory results, increase of public health data. And we've built an infrastructure in this country over the last 40 years to do that. A lot of it's called the Laboratory Information System, or systems in every laboratory. And those are largely absent from... admittedly. Very few laboratories in resource-limited countries have those. And any thoughts on your perspective as a non-laboratorian?
As a non-geek? Well, you know, and we started having this conversation at USC. Obviously, the great part of the platform is the internet. Mm-hmm. And what we've done, you know, and I want to be pretty humble about this. We did, as Partners in Health, introduce the first open source electronic medical records in Peru, Haiti, Rwanda, Russia. So, you know, we have some experience. The head of that team at Partners in Health is a cardiologist, as I mentioned. We were in LA, named Hamish Frazier. We've also, with the Brigham and Dana-Farber, tried to do something similar with some of our PATH results. I'm sure we have a long way to go. As you pointed out 2 days ago, the real challenge is partnership. And I believe that the partnership, the reluctance to partner comes from two sources. One kind of unattractive, and one, back to the question we just heard, that's really human frailty. And maybe both are a human frailty. I'm not really a philosopher or a theologian. And one is socialization for scarcity. I'm an anthropologist as well, did a PhD in medical anthropology. And, you know, I read a book when I was still in Haiti about how Haitian children learn they are socialized for food insecurity. It's kind of a sad book. It's a report, really, and it was called Socialization for Scarcity. That happens with NGOs, as you saw in Haiti over the last 2 years. It happens all the time. And that's why I imagine President Clinton said, we compete where really collaboration is what the modern world calls for. I think every thoughtful reflection on how we're going to make progress scientifically and technologically shows us that it's a really collaboration. And so that's the unappealing part. The human frailty part is it's really difficult to communicate, especially across barriers of language and class and professional training. So that's why, again, back to accompaniment, we have to be patient with each other because we come from different worlds. And I'm not talking just about, you know, micro versus histopathology. I'm talking about poor people, you know, who grew up in rural Haiti versus urban elites versus NGO X or Y or Z. And it takes a lot of patience. You know, and patience is not always easy to have. It can be a very frustrating kind of work. And, you know, I wish I were more patient. But I do think that we have the platforms, we have the technology. They're largely built on either the internet or lab developments that come from the lab, I think. Now, making our human relations and systems catch up with some of the technologies and the capacities that technology gives us is the biggest, I'd say it's the biggest human rights challenge for medicine and public health before us now. So thank you all so much for having me here today. It's been a real honor.
Thank you. Dr. Farmer.
Thank you. Thank you very much.
Dr. Farmer, we have one more order of business before we adjourn the session. Can you accompany to the podium, please?
I will accompany you.
Thank you. Walk with me to the podium. We have a theme here. So each year, ASCP presents a Patient Advocate Award to acknowledge distinguished contributions by members and volunteers and organizations or public servants whose actions through advocacy have furthered patient care and the field of pathology and laboratory medicine. Dr. Farmer, your dogged pursuit of patients' rights and access to care for the world's poorest people spectacularly exemplify the spirit of this award. For those who have not already done so, I urge you to read Mountains Beyond Mountains, the story of how Dr. Farmer built his nonprofit organization, Partners in Health, and started a care clinic that has become the model for health care for poor communities worldwide. So in honor of your work, to treat people who have infectious disease and curtail the spread of those diseases, and in support of your new campaign, to address non-communicable diseases amongst the poor, I'm pleased to present you with the 2011 ASCP Patients Advocate Award.
Thank you. Thank you very much. Thank you. Beautiful. Thank you. Over there?
I guess so.
Okay. Thank you very much. Thank you. Thank you, Las Vegas. Thank you all so much. Thank you, ASCP, and I look forward to working together long term. Thank you.
Thank you.
Congratulations, and thank you to Dr. Paul Farmer. This concludes our scientific address. Join us Friday morning for the next general session, Global Access to Healthcare, taking a look at cervical cancer.